Good morning, everyone. My topic. Good morning, everyone. So the topic for the today is lithium, and my moderator is Dr. Ayushi Gera ma'am. So the lithium is a mood stabilizer medication, antimatic that works in the brain, and it is approved for the treatment of bipolar disorder, also known as manic depression. Bipolar disorder involves the episode of depression or mania. So pharmacokinetics, it is rapidly and completely absorbed after oral administration. It does not bind to plasma protein and it is not metabolized, excreted through kidney. Lithium is also excreted in breast milk, and the blood-brain barrier allows only slow passage of lithium. Single overdose does not necessarily cause toxicity, and long-term intoxication is slow to dissolve. Hypothesis for mechanism of action. Lithium is partly replaced body sodium and is nearly equally distributed inside and outside the cell, in contrast to sodium and potassium, which are unequally distributed. And this may affect the ionic reflexes across the brain cells or modify the property of cellular membranes. However, related to sodium and potassium concentration, the concentration of lithium is associated with the therapeutic effect is very low, and lithium decreases the presynaptic release of noradrenaline and dopamine in the brain of treated animals without affecting the 5-HT release. Lithium in therapeutic concentration range inhibits the hydrolysis of inositol 1-phosphate by inositol monophosphate, and as a result, phosphatase, as a result, the supply of free inositol for the regeneration of membrane phosphatidyl inositides, which are a source of IP3 and DAC, is reduced. The hyperactive neurons involved in the manic state may be preferentially affected because the supply of inositol from extracellular sources is inadequate, and several other mechanisms involving the elements of neuronal signaling like glutamate, arachidonate, etc. have been proposed to explain the lithium action. So lithium inhibits inositol monophosphatase, and that decreases the free inositol, decrease phosphatidyl inositol 4,5-bisphosphate, which are the precursor of IP3 and DAC, and this causes the depletion of the second messenger source of PIP2, which causes diamine. Diamine. And which decreases the activity of PIP2 dependent pathways, which are markedly increased during the manic episode and which results to the mood stabilizing action. So pre-treatment for the lithium therapy, renal function test and serum creatinine concentration, thyroid function test, cardiac functions, weight measurement. Lithium is teratogenic. Women of childbearing age group should be advised to use reliable form of contraception. On treatment monitoring, lithium levels should be obtained every 2 to 6 months. 5 days of constant dosing. Steady state of lithium dosing is required before obtaining the blood for lithium levels. Blood sample must be drawn 12 hours after given dose. Dosage. Lithium is available in tablets, capsules, and liquid form, and no parental forms are available. The effective dosage of lithium is determined by monitoring serum lithium levels and assessing the patient's clinical response to the drug. Daily dosage generally requires 900 to 300 mg. More importantly, the serum lithium level should be about 1 milliequivalent per liter. Serum lithium level less than 0.5 milliequivalent gram per liter are rarely therapeutic, and levels of more than 1.5 milliequivalent per liter are considered toxic. Lithium is available in three forms: lithium carbonate capsules, lithium tablet, and lithium citrate in syrup form. And the most preferred form is lithium tablet, 300 mg, 400 mg, and it is preferred because it has consistent serum concentration, fewer adverse events, and improved adherence. Adverse effects are: number one, cardiac effects. T-wave flattening or inversion of ECG due to displacement of intercellular potassium by lithium. And these changes are benign and disappear after lithium is excreted from the body. Lithium depresses the pacemaking activity of sinus nodes, so contraindicated in sick sinus syndrome. Post tremors, notable in fingers when hands are outstretched and during tasks involving the fine manipulations. Cognitive effects, dysphoria, lack of spontaneity, slowed reaction time, and impaired memory. Thyroid effects, goiter, hypothyroidism, exophthalmos, and rarely hyperthyroidism. Gastrointestinal effect, appetite loss, nausea, vomiting, and diarrhea. Renal effects, polyuria and secondary polydipsia. Lithium toxicity, mild to moderate intoxication. Lithium level is 1.5 to 2 milliequivalent per liter. Moderate to severe intoxication, lithium level is 2 to 2.5 milliequivalent per liter. And severe intoxication, lithium level is greater than 2.5 milliequivalent per liter. Management of lithium toxicity. Lithium should be discontinued. Vital signs and neurological examination with complete formal mental status examination should be done. Lithium level, serum electrolytes, renal function, and ECG. Emesis, gastric lavage, and absorption with hexylate. For any patient with serum lithium level of greater than 4 milliequivalent per liter, hemodialysis should be done. Drug interaction. So with ACE inhibitors causes increased sodium loss leading to increased sodium reabsorption by kidney, resulting in the increased plasma lithium levels. Thiazides causes reduced renal clearance of lithium. Anacids causes it inhibits the renal prostaglandins, renal reducing renal blood flow and increasing the renal reabsorption of sodium and therefore lithium. Carbamazepines can cause the hyponatremia, which may in turn lead to lithium retention and toxicity. Metronidazole causes increased lithium concentration. So references used are Maudsley prescribing guidelines, Godman Gilman's pharmacology, and Kaplan and Sadox and Oxford Secretary. Thank you.
What are the dosing? Dose is generally from 900 to 3600. Please don't go do an MD from there and get 3600. Please don't do that. These doses are out of a very broad range. This kind of an heroism we don't want. Okay. So what we do is clinically we start with 300 milligram, either OD or PD, then subsequently titrated. We generally don't go beyond 900 or 1200. Levels accordingly can go to 1500. Generally, Dr. Vina, where you want to? So, but because this is these are all Western data. This is, I would say, little those Western population very controlled conditions. That kind of a thing is not applicable there in our culture, in our economy, because where lithium levels are not done frequently, are not available. The quality of testing is very questionable. So, play safe. Okay. Safety of the patient is also paramount. First ethical principle of treatment is what? First ethical principle of a treatment is what? Huh? क्या कहते हैं उसे? First to know how. Non-maleficence. Then what comes? Beneficence. Then you will benefit the patient. This is very, very important. I think you have done that. Overview there, which is 10 minutes presentation. Managed each and every line also. So I think that we appreciate. Questions? Neurobiology of this neurophysiology, this neuronal neurophysiology. Which I had करना चाहता. She said about tricellular cholesterol. She said then about those PIP2, and other things. Anything other than that? There are a lot of pathways in why lithium is important depression. Why it is also an antidepressant or depression prophylaxis area. I really like the term anti-manic. Nowadays they say that mood stabilizers. These medications are not some electricity stabilizers. They say they are anti-manic agents and antidepressants. So mood stabilizers in latest CANMET, you'll see they have never used in whole CANMET mood stabilizer. They have avoided that. So preferably if we say no, we would anti-manic or antidepressant. That is more preferable. Right. So they can go on 14 minus A, 14 minus C, subsequently DAG will result in increased formation of 14 minus C. Yes. And then subsequently the W20 pathway, now BDNF has also come into the picture. Initially, there was a lot of excitement around it. Now it has come down. And then subsequent further signaling. Okay. So this is very, very important. Okay, so manic neurons which are firing and having very high levels of protein kinase A, protein kinase C. How lithium goes and calm it down is actually it results in reduction of its level. Protein kinase C, protein kinase A, this W20 pathway and other pathways. So this is worth remembering. You'll see CTP, they have actually lined it up 11 or 12 hypotheses, right? एक presentation. So where is complete? Where is the 10th slide? Who wants certificate? कब करेंगे? लेटर में डालेंगे, इनवाइट करेंगे, जब नेक्स्ट टाइम आदमी था last time told you we'll do on Saturday. When you want it to happen, कब करोगे? Monday कैसे कर लो? Tuesdays you don't want to do that. Generally you are accommodating internal presentation और वो जिस दिन है उस दिन करना है. Saturday is also a case conference what we are doing because देखो आप लोगों का presentation नहीं होता है. आज कर लेना. तो 10 स्लाइड बनाने में टाइम लग रहा है. So, whom you will invite to felicitation for the partner. But I think it was a good right? Line by line, every line was a good. It didn't waste one line. So, one question for PGs is you said NSAIDs, you said metronidazole, these antibiotics, and all sorts of things interacting with lithium. From where it increases the levels of the which part of the nerve is proximal, except so only one drug results in retention of lithium levels via other part of the nephron, which प्रोस्टाग्लैंडिन्स वगैरह काम से काम कहाँ काम करते हैं देखो सब एमबीबीएस को पता होगा आप लोग तो रीनल नेफ्रोलॉजी पढ़े डिस्टल सो एनएसएआइड्स आर ओनली एजेंट्स तो आपने जैसे एनएसएआइड भी दे रखा है मेट्रोनिडाजोल भी दे रखी है और लिथियम भी चला रखी है तो मैसिव इफेक्ट होगा क्योंकि पीसीटी भी जाएगा लेगा और पीसीटी की अपनी कैपेसिटी है जो छूट जाएगा पेशेंट माइट गो वेरी क्विकली टू lithium toxicity is a very important thing. And what we presented in the first slide, कि वो जो CNS उसकी entry है ना, half life of CNS distribution. Lithium has two different distributions. Tissue distribution अलग है, CNS distribution अलग है. So CNS distribution also happens late, and its elimination also. Toxicity suddenly नहीं आएगी. 10 tablet खा के आया patient process किया जाएगी ऐसा. Patient will not appear to be clinically stable, but later on patient might. One. Secondly, it will not resolve quickly. Toxicity होगी तो क्या करेंगे? Dialysis वायलिसिस तो हमारे यहाँ से obviously 20 टैबलेट खा गया तो देंगे नहीं. One tennis day. That is very important. Without doing all those levels and blah blah blah, you immediately start and down the line. And see if you can go for lavage. If there is a time window है अगर absorption हो चुकी है भी करते हैं इसलिए lithium का absorption जाना lethal dose कितनी okay? So if patient has come to me with 15 dosages 15 tablets of overdose of maybe nitrazepam or 30 tablets actively suiciding, so you admit the patient after 4 days he wants to come home. Will you give me? Reporting window है ये खा गया तो नहीं शायद बच पाएगा. So इसलिए you will probably avoid it, take a little bit longer period of time, follow him up closely, or little assured कि active intent नहीं है या एक adequate observation है patient monitoring में medicine चल सकती है, assured या you have that kind of assurance, still you can take it. एक electrolytes वाला एरिया बहुत interesting था. ये क्या है? Interactions क्या लिखे हैं? Hypokalemia, hyperkalemia, hyponatremia, hypernatremia, hypoglycemia, hypoglycemia. 6 हमसे वही पूछते हैं इन 6 हैं से क्या इंटरेक्शन है काइनेटिकली डायनामिकली whatever. हाइपोनेट्रिक में बताइए टेंशन करके नीचे में उड़ा देगा हाइपोकैलेमिया हाइपोकैलेमिया सो हाँ हाँ हाइपो आइडिया yes which is the most dangerous of this food जो आपको देखना है, और लिथियम या तो बंद कर देना है या बहुत ज्यादा प्रिकॉशन रखना है। पोटेंशियल, यस, टाइपों के लिए, बिकॉज कार्डियोमायोसाइट्स they go very intense cardiac, the excitability increases. Lithium देंगे, patient might go immediately into some kind of cardiac arrest. So you have to be very, very careful to hypocalcemia. As such, hypercalcemia, they themselves are very dangerous. Most of the action, neuronal action inside a cell takes place by calcium. But you have to read it. You all have to read it. ये all आपसे सब आपके MCQs हैं, जो आपको बताना है। एक ही क्वेश्चन पूछते हैं, डॉक्टर वीना पूछती है हमसे कि सर ये रीनल टॉक्सिसिटी का क्या है प्रॉब्लम, कहाँ से प्रॉब्लम? रीनल टॉक्सिसिटी एंड लिथियम, सो व्हाट यू नीड टू बी वेरी वेरी केयरफुल। पेशेंट कमिंग टू यू इज पेशेंट कमिंग टू यू कि सर ये जब से डॉक्टर वीना लिथियम चलाई है ना, आप तो थे नहीं डॉक्टर वीना बैठे तो लिथियम चला दी और हम तो रात रात भर पेशाब कर रहे हैं। व्हाट यू मेक ऑफ इट? लिथियम यूज सही यूज ओनली इस चीज से होता है, और ये भी है कहाँ से related to peak levels of the drug, trough levels of the drug. Renal issue can't hit that, CNS issue can't hit that. So renal side effects are related to trough of the drug. If you reduce the peak, you reduce the drug. क्या करेंगे? हाँ? Use a dose. हाँ, good. Actually, ऐसा most of the polyuria is resolved by given ऐसा or acidic. ठीक है, तो उससे क्या होगी, आपकी सस्टेन लेवल्स रहते हैं, तो पेशेंट्स खत्म हो जाता है, कुछ लोगों गायब हो जाता है, कुछ लोगों रहता है। फिर कहते हैं कि लिथियम तो जरूरी है, इतना बढ़िया तो कभी नहीं हो पाया, फिर भी पॉलीयूरिया हो जा रहा है, हो जा रहा है, हो जा रहा है। तो लिथियम देन योर दिस ऐसा ये गेट्स सिस्टम में होता है कि वेयर यू हैव टेकन ऑल द प्रिकॉशंस, अब क्या करें? हाउ यू विल ट्रीट? सिंपल क्वेश्चन एमसीक्यू है। Lithium induced polyuria not responding to the conventional dosage example and will require the patient क्या करें? थोड़ा वाटर रेस्ट्रिक्शन करा के देख लेंगे, उससे भी कुछ होता तो नहीं। जनरली न्यूरो सर्जन पे जाओगे तो वाटर रेस्ट्रिक्शन करा, मोस्ट ऑफ देम विल बी टेकन। नहीं होगा तो एक डायूरेटिक सिंथेटिक डायूरेटिक इज गिवन, डायूरेटिक इज गिवन to treat diuresis by excellent concept. Thiazide diuretic, very good. So thiazide diuretic इंटरेक्ट करेगा लिथियम से, उसका लेवल बढ़ाएगा, क्या करेंगे? पॉलीयूरिया भी कराएगा। थेरेप्यूटिक यूज करेंगे, लिथियम की डोज को हाफ कर देंगे, फिर रिटेन करेगा तो अपने आप लेवल पे आ जाएगा, पॉलीयूरिया भी कम कर देगा। बट देन यू हैव टू डू इट इन license with the physician or nephrologist, because we are not trained to do this and monitor. तो ये कुछ तो चीजें हैं जो इंटरेस्टिंग है, थोड़ा शेयर, और ये सब पूछी जाती है। Dr. Veena, any comments? Very important. So हम लोग साइकोलॉजी को देखना पड़ेगा कि अगर इनके एक दो दिन का है तो ठीक है, तो बंद करो, ठीक है? Any questions? Any questions you have? Lithium. Lithium resembles what? Hmm? और ये जो एटॉमिक टेबल में कहाँ आता है? Lithium was first discovered. First discovery. पहली डिस्कवरी कब हुई थी? 1870 by Berzelius. Berzelius बड़ा famous था. Then exam में पूछा जाता है when was it first used for as an anti-money game? Yes, very good. You are very good. And first trial, first systematic control trial. Japanese scout. Which is your favorite? Scout. SCOU. Dr. Scout did it. And when it was approved by FDA, approval कब मिला? 1970. ये जो आज तक चल still one of the best. So one of the best agents. Given you use it judiciously. Don't go for heroism, mix, over enthusiastic. This is what it is. Thyroid function test. Hypo. Hypo भी करता है, कितने परसेंटेज में करता है पूछा जाता है, कैसे करता है पूछा जाता है, रिवर्सिबल होता है नहीं होता है, ठीक है, वोल्टा कराता है नहीं कराता है पूछा जाता है. So generally what I tell here is because this is an endemic region where there is very less iodine in the food products. So tell them avoid cabbage when they are on lithium and obviously iodized salt. क्योंकि बहुत घरों में यहाँ पर सेवा नमक है. I think सेवा नमक is rock salt जिसका iodine होता है. That is now they are commercialized rock salts going to iodine supplementation. This is very important. Otherwise you might lend them into hypothyroidism later on. This kind of a precaution, how much they help, we don't know. This is what it is. Then there are very important phenomena, physiological phenomena known as Wolff-Chaikoff effect, George-Bidso effect. ये सब पढ़ना, ये सब interns ज़्यादा information आपको पता है कि पढ़े थे ये सब. This is related to iodine. Iodine, जहाँ lithium आएगा वहाँ iodine आएगा. Lithium is something जहाँ बच नहीं सकते. So in 2 drugs you have to read almost day in day out is lithium included. How much ever you reading do this reading, it is not enough. You need to know. And the benchmark is that the CTP, the latest CTP, the older versions, उतना तो पता ही नहीं. तो एक first step. Then you need to develop it, read more and more and more, and then you will gain those experiences. Syrups available है नहीं होना पाए. मैंने देखा तो नहीं available है. And हमारे यहाँ ये जो salt आता है कौन सा आता है? कार्बोनेट आता है. और कौन से होते हैं? Sulfate. So ये सब चीजें important है. Then इनके भी अपने variations हैं, kinetic variations हैं, जो पढ़ना बहुत जरूरी है. Lithium levels की बात हुई, तो ये कब तक आते हैं? What thing you will actually take into consideration is the preparation of the lithium, which is heavy. Whereas is only for the preparations. If it is an SR preparation, what will you do? SR preparation के क्या ये जो lithium level 12 घंटे बाद क्यों बढ़ा? ये स्टडी स्टेट लेवल पिक करने के लिए कराते हैं. स्टडी स्टेट लेवल में भी पीक्स आते हैं, उसको पिक करने के लिए कराते हैं 12 घंटे बाद. फिर आपको उसका आंसर पता चलेगा कि एसआर जब हम लोग एक्सटर्नल रिलीज देते हैं तो अगर हम 12 घंटे को कराते हैं तो हमें 20% डोज पे जस्ट तो घटाएंगे या बढ़ाएंगे. ओके, स्टार्ट करो. The patient has been transferred.